So today we're talking about the Centers for Medicare and Medicaid's efficiency measure, which has been around now for a couple of years, but we're finding that because of all the exciting and new changes in healthcare reimbursement, including your accountable care organizations, your bundled payments, and some of the other more creative payment methodologies that CMS has come out with in the last couple of years, we're finding that we have to be ever more diligent as it relates to this efficiency measure, which has all to do with length of stay and cost of care, two of the things that are always on our radar as hospital case managers. So we're going to talk about the measure itself, and then we're going to talk about the things that we can do as case management professionals to respond to this measure to help our patients and to help our healthcare systems in general. So just some background statistics that, you know, they fluctuate a little bit, but they've been fairly constant in terms of the concepts over a number of years. So we still see that about a third of all of our healthcare dollars are spent on hospital care. That's not as bad as it once was, I think, because so much has moved to the ambulatory setting over the years. Per capita spending, almost $10,000, and I'm sure you're aware that that's twice as much as any other industrialized country in the world. And there's a lot of theories about why that is so. That's a debate unto itself. We spend almost 18% of the gross domestic product on health care. So that means that 18 cents out of each dollar spent is in our economy is spent on health care. And again, that's very high. There were thoughts quite a few years ago that the prospective payment with the DRGs was going to level off that cost, and that absolutely did not happen. Uncompensated care, now that can be charity care or that can be folks who are partially paying, things like that, 5.6% of revenue. So again, most businesses would not be able to sustain themselves by losing 5.6% of their revenue for services already provided. And these numbers, the last bullet, were updated just recently. We are 45th in life expectancy and 45th in infant mortality across the globe. And so while we spend the most, we certainly aren't getting the quality of care out of it that we would expect to get. So, you know, the question becomes, how can I, in sort of a broken healthcare system, make things better? And that's really what we're all about today. So because the efficiency measure falls under our value-based purchasing domains and measures, just to refresh ourselves, right now we have 4 categories under value-based purchasing, and the one we're talking about today is your third there, efficiency and cost reduction. So what CMS essentially was saying was, in addition to outcomes and how you provide clinical care and whether or not patients are satisfied and whether they're safe, we're also going to tell you that you've got to start managing your cost. And you're going to manage your cost by being more efficient. You're going to manage your cost by being sure that you're treating patients correctly. So this was an attempt at getting us to think differently. I mean, we've always thought about cost savings, but we weren't really ever measured on it. So as you can see, it started as 20% of our overall value-based measures I'm sorry about that column there, in 2015. So it's not that old, really. So it kind of looks like this. So you've got your HCAPs, and I would venture to say that if we're doing a good job in terms of efficiency and good communication with our patients, that we might also see a better HCAP score in some instances. Your clinical care and outcomes, 25%, as we just said, efficiency and cost reduction. So everything is 25% now. And as we know, that translates to, if you don't do well in these domains, that you are at risk for losing up to 2% of all of your Medicare payments. So it's an across-the-board reduction on all your Medicare billing for whatever period of time you're looking at. So it can be a scary metric, and we'll talk more about that. So the first efficiency measure as it looks at this current time is this. So if we look at the ball in the middle where it says hospital admission, that's sort of the center of this efficiency universe here. And the measure itself spans from 3 days prior to admission through 30 days after discharge and includes transfers and readmissions. So theoretically, you could get penalized twice on the same patient as it relates to readmissions. So if you have one of these patients readmitted within 30 days, that's going to count within your efficiency score, and it's also going to count against you as a 30-day readmission. The efficiency measure also includes Part A and Part B spending. So as you look across the span here, that makes the notion of thinking about case management as solely a hospital model, even if you work in the hospital, because of these measures and some of the payment methodologies I talked about at the start, you begin to see how it becomes pretty crucial that you're thinking much more than just within the walls of the hospital, but thinking beyond the hospital walls as well, because we have a part to play in where our patients go after discharge. So the claims that are used for this measure, they're used in both the hospital IQR and the value-based purchasing programs, as I said. And so they're looking again at your Part A and Part B beneficiary spending during that period of time. They had originally proposed that they look 90 days out after discharge. There was a lot of pushback on that 90 days benchmark, and they brought it back to 30 days. So again, you've got your transfer. So if you get a transfer who's already, already spending a lot of money and has a long length of stay post-discharge, you may very well see that problem crop up in your efficiency measure, as your additional admissions and readmissions are included. And of course, what they're looking for you to do is be more cost efficient. And the two ways we know how to be most cost efficient are by managing consumptive resources, meaning the resources consumed by a specific patient on a specific day and stay, and to, of course, control our length of stay. So when you look at this particular measure, you're looking for a lower number rather than a higher number, so better is lower in this case. They also have some adjustments that they allow for. One is for age and one is severity of illness. Now, it's not severity of illness in the way that we think of it in case management. This is based on specific diagnoses that they run in the order, starting with the one that they consider at the highest, and then they go down from there. And it has more to do with the span of resources, not just in the hospital, but across that continuum. If you want to see your own efficiency score, first you would go to www.cms.gov, and then when you get on that website, if you've not navigated through there before, you can go to search for Hospital Compare, and that's where you're going to find all of these things. You can put in just your hospital. You can compare your hospital to multiple other hospitals, but if you just want to see your own score on this or anything else, you simply just go to Hospital Compare within this giant website. It can be a little overwhelming. I've gotten lost in there a couple of times, but if you persevere, you should be able to find it. So the spending per hospital patient under Medicare, or the spending per beneficiary, as it's called, looks at your hospital, whether it spends more or less or about the same as other Medicare patients treated in other hospitals nationally. So as we said, it includes Part A and Part B. So what they do is they a ratio is calculated by dividing the amount your Medicare spends per patient for an episode of care initiated at your hospital by the median or the middle score amount Medicare spent per patient nationally. So you might say, today I'm doing really well with this particular measure, but everybody else, so we're not going to do anything, let's say, and everybody else is working hard to improve their measure, and you just stay the same. Because you're compared to the nationally in this ratio, you're going to start to lose ground, and you're not going to hold on to that pretty good score for very long. So these scores are intentionally meant to compare you to the rest of the country and to keep us being a little competitive and moving forward, because as we compete with other hospitals nationally that might be improving and we're not, we're going to see a worsened score for us. So when you see your ratio equal to the national average, that means you spend about the same amount, as I said, and if it's more than the national average, you're clearly spending more, and the same with less. So again, you want to find that lower score. Now, they originally started out with sort of the benchmark at 1.0 or 100, and now I think they've dropped it to 0.99. So you got to do better. So who affects the spending per beneficiary metric? Well, if we're thinking about that continuum of care, which we clearly must as hospital case managers, we really have to think about that broadness of that of the care that a particular patient might receive. Of course, any provider along that care continuum, whether it's the doctor's office, whether it's the emergency department, the hospital, or a subacute facility, any physician or other care provider can impact on that spending. The family can have an impact, the patient can have an impact, and just as an aside, none of this includes Medicare Part D. Externally to the hospital, those care providers up to 3 days before the patient is admitted and 30 days after hospitalization. So yeah, I was working with a hospital a few weeks ago, and there was pretty much a knee-jerk response within their discharge planning process because they were depending so much on physical therapy to decide where patients would go after discharge that a high proportion of their discharges were all going to subacute. You really have to be more diligent than that today, because there are many patients perhaps who would also benefit properly or receive the care that they require at home with home care, for example. Simple example, but it's an example of where if you just kind of keep doing things the same way and aren't using that critical thinking that you need to use to send the patient to the right, least expensive, least intrusive level of care, then you're not going to get this score where you want it to go. And we don't really want to expose patients to institutions that they don't need to be in if another level of care will give them what they need. So always to think about that in your discharge planning process. So your discharge plan can also affect ultimately what your score is going to be. So this score is in many ways very far-reaching. Okay. Other things that are going to affect your score come from the costs that are incurred within the hospital itself, as I said before. And we're going to talk about measuring cost of care in a minute. But, of course, your care providers. And, you know, back in the day we used to say the physician had the power of the pen. Now I like to say the physician has the power of the mouse. And it's the physician who's likely to be possibly over-ordering those resources. Delays in service, of course, a patient's waiting for tests, treatments, procedures, consults. What does that do? That extends your hospital stay. Depending on the kind of managed care contract you have, it might result in a denial, and it increases cost with no value added for that patient. Same thing with overutilization of resources. So when we over-treat patients or we treat patients for things that are not related to their current admission to the hospital. This, again, puts us at higher risk for a bad score. And always you'll see the family and the patient listed because they, too, can impact on our score. So as I said, let's talk for a moment about measuring the cost of care. You have to know how it works in order to be able to effectuate any kind of change with the cost of care clearly. And this measure, of course, makes us think differently about things. So what is a cost accounting system? Your hospital may or may not have a cost accounting system as we talk today. A lot of hospitals do, and a lot of hospitals still don't have cost accounting systems. There's a lot of suspicion that cost accounting systems may or may not be accurate, that it's junk in, junk out kind of a thing. So some organizations have still shied away, but there will become a point where it's absolutely impossible. I think we're there, frankly, for a health system not to be able to survive without some kind of a cost accounting system. So it's basically a system, an IT system, for recording, analyzing, and allocating cost to the individual services provided to patients. So we can think about cost in two ways, and we think about that as direct. I like to think of them as direct and indirect costs. So direct costs are the items that we provide to directly care for a patient. Medications, the cost of a procedure or test, x-ray, anything like that, and room and board fall under the things that go to directly care for a patient. Then we have the indirect costs, and these are the costs that the hospital sustains whether or not there's a patient in that bed. So indirect costs are insurance and light and heat and air conditioning and anything like that has to be, it's a fixed cost essentially. So if your hospital has a cost accounting system, you should be able to go into your system and look at the costs and the average for either one patient or a diagnosis or a physician, which is really helpful when you're trying to figure out where your opportunities for improvement might lie. If you don't have a cost accounting system, you can rely on less accurate measures. The most common one is RCCs, or ratio of cost to charges, and that's just a guesstimate as to the cost. So as I said, I really do believe that we have to have a cost accounting system in all of our organizations, and that would include the post-acute world as well, because we all need to understand where our cost is being spent. So whether you're an accountable care organization or you're trying to negotiate an appropriate rate with a third-party payer. So a managed care company, for example, particularly in the earlier days of managed care, hospitals would sit down and, quote, negotiate rates without knowing what their true cost was, which I always find amazing, because it would be like saying, all right, you're going to pay me $10 for this pair of shoes, but I have no idea how much it cost me to make this pair of shoes or this car or whatever it might be. And that's exactly what we were doing in healthcare and still are to some extent. We're not sitting down and saying our average cost to treat this patient is X, and therefore we need that amount to break even. We don't always know that information. We also need to know what our costs are to look for our cost reduction opportunities. We need to understand total cost of care for a patient from inpatient and outpatient. And the thing that I always found most interesting when I've put together report cards that, let's say we do a report card on, I don't know, fractured hips or something like that, I want to know the relationship between the finances for fractured hips and the clinical outcomes. Is what I'm spending getting me those outcomes that I expect? We can't assume so, because as we saw, we don't do very well in terms of quality of care and outcomes as compared to the amount of money we spend. So there's probably opportunity in there for most of your stuff. So what is value then in healthcare? Well, value has to do with your outcomes that you've achieved per dollar spent to get to those outcomes, as we just said. So that's your value, and it's defined around the patient, not around the hospital. So when you're looking at those direct costs related to the care of a specific patient, you're looking to see what your value metric is, and it's measured by that patient's cost and the outcomes, not the numbers of patients. Now, that's value. That's different from your senior executive wanting every bed filled so they can bill. That's a different thing here. Now we're talking about value. When you look at a value metric like this, you're looking to see whether you're efficient, whether your care coordination processes are adequate. Are you spending the right amount to get to the outcomes that you want to achieve? And it relates to your patient's total cost for that full cycle. So if we're thinking again in the context of the efficiency measure, that full cycle will be from 3 days before admission to 30 days after discharge. And it may be easier in your organization to measure this in a bundled payment structure because of the way that bundled payments are managed and paid for. So value equals outcomes divided by cost. How much does it cost me for a patient to achieve those expected outcomes? Then the question is, of course, well, what outcomes are we talking about? In case management, I like to think of it in 3 buckets: financial outcomes, clinical outcomes, and service outcomes. So for our financial outcomes, again, are we managing our costs and our resource consumption? Clinical is whatever those clinical indicators are that we're trying to achieve, of course. And service has to do with satisfaction, and that is absolutely a metric because we want to think about keeping patients satisfied and returning to our organization if they need to. I wanted to mention choosing wisely. They have a wonderful website that you can visit, and what they talk about is resource consumption. They've put together guidelines for specific diagnoses, the use of ancillary services like radiology, how to progress a patient without compromising quality. It's free of charge. You can check it out. There's a lot of good information on there if you're working on a project to manage your cost and you want to use some evidence-based data to help you to do that. So they say that your resources that you should be spending should be based on supportive evidence, yes, should not be duplicative. So we don't want to do multiple things for the same patient over and over again that aren't, again, adding any value, that they're truly necessary and they're free from harm. And if you look at what CMS says about this, they're basically saying the same thing. You don't want to do any more than you need to do and no less than what the patient requires. So because in the efficiency measure, length of stay is a huge piece, I thought we'd just quickly go over the ways in which we measure length of stay. And there's sometimes some confusion as I go into some hospitals as to how your specific hospital is looking at this particular metric. So first, of course, we have the actual average Medicare length of stay. And as of 2015, and I must see if I can get an update, it's very hard to get these updates. Last time I checked a couple of months ago when I worked on these slides, we didn't see anything. So we're going to look again. But it was 4.5 days. And I'd venture to guess it's been pretty flat for a while. And that's because, you know, I like to say that low-hanging fruit is pretty much gone as it relates to length of stay. And that's different. Your actual is different from your expected length of stay. And your expected length of stay, after all is said and done, whatever DRG that patient's chart gets coded into, and that's impacted by complications or comorbidities that may have been coded based on the physician's documentation in the medical record, and that's going to drive perhaps a higher weighted DRG that allows for those complications and comorbidities. Your expected length of stay can vary, and it can vary by the way in which it's measured, for example. So you need to know which metric your own hospital is using if you're looking at length of stay data. And there's two ways: the geometric mean, or GMLOS, which reduces or takes out the effect of the very high or very low lengths of stay, which might bias your mean or straight average when that is used. So that's one way, GMLOS. And then the other is a straight arithmetic mean length of stay. So that's just, adding up your lengths of stay and dividing by the total number of discharges. It's a straight mathematical average. You want to know which one. Everybody says average length of stay, but that may or may not be what your hospital is using. So it's something you need to know and understand. It should be labeled by your finance folks, perhaps, who are providing you with that information. So we care about length of stay for all the reasons we've talked about, but also because most of our payers today are paying at the DRG or case rate. And so you'll see that for your government payers, your Medicare, your Medicaid in most cases, and you're going to see it with your commercial payers for the most part as well. So we care about length of stay for that reason. We also know we don't want to keep patients in the hospital any longer than we have to. The longer they stay, the increased probability that an error might occur. Length of stay is publicly reported today, so it's this transparency of the data means that we want to do due diligence with this and all the other metrics. A length of stay gauges our hospital efficiency. So if the expected length of stay was 4 days and our average on that one is 5 days, that can mean that we're just not as efficient as we should be. Attracting managed care contracts. If you have an efficient hospital, not only are you going to have more negotiating power with a managed care company, but you may even get more contracts out of it. Keeps you competitive. It aligns you with regional and national benchmarks, which is something every organization wants to do. And now, of course, it's very important for our efficiency measure, the topic of today's discussion. So expected versus actual length of stay. So what impacts our actual length of stay? Well, your patient flow processes. And when I speak of patient flow, I'm not talking about a group that sits in a conference room every morning and goes over how many discharges there are going to be and how many OR patients there will be and how full the emergency department is. Yes, that's all metrics of patient flow and have to be understood. But for case management, we also want to understand what is delaying our care progression for our patient, how efficiently we move the patient from the ED to the floor, how efficiently we perform the discharge planning process, and how efficiently we look at resource consumption or overconsumption for that particular patient. So it has a lot to do with coordination of care. So it's hard to tease coordination of care from patient flow because they are so intertwined. But coordination of care, to me, is the key to managing length of stay. Physicians and other care providers, as we said earlier, the power of the mouse, they are going to affect the length of stay. Getting consulting specialists or others in a timely manner, and really questioning whether or not that consult needs to be done while the patient is still in the hospital. Delays in care, all those delays because services aren't available 24 hours, 7 days a week. So ancillary services as well, and just overall delays and scheduling, ability to schedule. And just a little factoid, the higher your occupancy rate, meaning how many beds are filled, the longer your length of stay will be. So the higher if you're running at 100% occupancy rate, you're going to see your length of stay actually creep up Does that sound counterintuitive to you? Well, why is that? Well, because you're not adding MRIs and ORs and CAT scans and all the other tests. You're not adding that equipment. You're not adding personnel during periods of high capacity. So the queue, the line that the patient has to get on to get that test done actually gets longer and affects your length of stay. All your services essentially get taxed during periods of high occupancy. So one of the metrics I would look at every day as a director and as a vice president was to not only look at the length of stay, but also to look at the occupancy rate as a red flag. Avoidable delays is another one, or days, or however you like to call them, variances. So delays in this regard also things that caused a delay in the length of stay but could have been avoided, all the things that we were just discussing. Not every delay is avoidable, of course, but many are. So how good is your discharge planning process? That's another question. Do you start on the day of admission? Do you have the right people doing the right things as it relates to discharge planning? You may see a longer length of stay for those unfunded or underfunded patients who don't have resources available to them in the community, perhaps because of their insurance plan or lack of insurance plan. Sometimes we see a challenge in accessing post-acute care resources because of where the hospital or patient are located. Effective communication can absolutely positively affect your length of stay as well. So when that team is coordinating care as a team, that makes a big difference. And then not treating patients for reasons other than the one that brought them to the hospital, this rabbit trail treatment that we go down because the physician is afraid the patient isn't going to come back after discharge and get the test done or whatever the issue might be. There's always exceptions, but as a rule, we don't really want to do that. And we did talk about what impacts the actual expected length of stay. So yeah, that coding, what the coders are able to glean out of that medical record, like complications and comorbidities, and that's based on documentation. And how good is your CDI program, Clinical Documentation Improvement Program? CDI programs can make or break a hospital these days. They can affect improve reimbursement up to millions of dollars. So I don't believe that any hospital can survive in today's world without a CDI program. So documentation is part of this, of course, and it's part of this because of the fact that the documentation drives the reimbursement. So that clinical information should be absolutely reflective of the care that was provided to that patient during that hospital stay. So it'll drive your reimbursement, which is affects your case mix index. Your case mix index is simply an average of all of your relative weights for all discharges for a period of time. Your hospital-acquired conditions can affect your reimbursement, as you might get penalized, and of course, value-based purchasing. It also tells you something about your risk of mortality, your severity of illness, and your complication rates. So for the efficiency measure, you want the documentation in the medical record to actually match the acuity level of the patient. And I think we have some responsibility in that. Yes, we might have clinical documentation improvement specialists or whatever title you might use for these folks, but we are rounding with the physician, and we are listening to the plan of care that that physician is effectuating. And when that documentation in the record doesn't match what the physician's thinking is, then that's an opportunity for CDI to step in. I've even had CDI attend rounds so they can hear what the physician's train of thought is. So the input is the clinician's documentation, and the output is reliable and accurate healthcare information that can affect expected outcomes and reimbursement. So documentation today is sort of a linchpin all around the business that we perform, this business of healthcare. So how do we pull this all back to what we can do in case management? Well, it gets back to our 4 basic functions: utilization management, care coordination, discharge planning, and resource management. So I told you that care coordination, in my mind, is really fundamental to your ability to manage your efficiency measure. So what is it? It's the deliberate organization of patient care activities between 2 or more participants, including the patient. So we always want to think of the patient as part of the team, involved in a patient's care to facilitate the appropriate delivery of healthcare services. And from the National Center for Biotechnology Information, organizing care involves the marshaling of personnel and other resources needed to carry out all required patient care activities, and is often managed by the exchange of information among participants responsible for different aspects of care. And that's exactly right. So one of our challenges, of course, in today's busy hospital setting is to figure out how we get that coordination, how we get that communication working correctly. And part of that is having some kind of interdisciplinary care rounds. So the Center for Biotechnology Information goes on to say that there are 5 key elements of care coordination. Numerous participants are typically involved. So yeah, as a case manager, you are not going to be performing care coordination in a silo or in a vacuum. You've got to do it in concert with all the members of the interdisciplinary care team. Coordination is necessary when participants are dependent upon each other to carry out disparate activities. So yeah, the physical therapist is doing one thing, the staff, bedside nurse is doing something else, case management is doing yet another thing, the physician. So everybody has to bring forward their information in order to carry these activities out in a coordinated way. If we don't know what each other is doing, how can we possibly coordinate and manage those processes? And so exchange of information is critical. So integration of care activities has the goal of facilitating appropriate delivery of healthcare services. And rather than having to chase around to talk to all your team members about different patients, how much simpler is it to bring everybody together at a standard time every day and discuss that patient, or all those patients? We should see seamless transitions also for our patients. Seamless means perfectly consistent, continuous, or flowing, and no bumps or ridges or irregularities, and we should always be striving for that. And then the transition of our patients in terms of discharge planning, moving from one stage to another. So for our purposes, we're thinking of the stage of acute care transitioning to perhaps subacute or some other level of care. Alteration of a physician system from state or condition to another, shifting gears or passage from one phase to another. So it really does all come down to these transitions. So we have the coordination of care while the patient's in the hospital. We also have to coordinate the transition of the patient from beyond the walls of the hospital. So it's a core business of the hospital, and it's one of our core responsibilities as case managers. So if we think about the hospital transitions and the community transitions, the patient actually has to transition through the course of the hospital stay, right? So as we said, from the emergency department to the point of discharge, there are multiple transition points that happen during the acute care phase. Then the patient might move to the community, through the community, or through a disease process or situation, because not every patient is going to remain a patient in the community if they're, it's a simple gallbladder or something like that. And sometimes they get transitioned from one provider to the next, and these are the points in which we have to do extra careful diligence when patients are moving from one provider to another provider, because that's where the baton can get dropped. That's where communication can fall short. So transitional planning is really a way to facilitate the transition of that patient from one level of care to another. And this really has to do with one level of care to another within the acute care setting. So planning your stay from door to door. As your patient enters and you begin assessing that patient and thinking about where they're going to go after discharge from the hospital, you've got to think about what the plan will be to effectuate that movement. Working collaboratively to determine what the next correct level of care will be. Connecting the patient, and we're required to do this under the conditions of participation, to connect that patient to the post-acute care level. Transition the patient, and better transitional planning results in better patient flow optimization. So this quote here, this paragraph, is from A Family Caregiver's Guide to Hospital Discharge Planning. I do encourage you to look at this website, caregiving.org. It's got so much helpful information on here for you. Again, free of charge, and tools you can use to assess caregivers that are in multiple languages. It's really a really helpful website. So patients' families or patients themselves might say sometimes it seems as though discharge happens all at once and in a hurry. But discharge planning is a process, not a single event. And Medicare defines discharge planning in this way: a process used to decide what a patient needs for a smooth move from one level of care to another. And you have to be thoughtful about what you say to our patients and family members. You can say things like, discharge from a hospital does not mean that your relative is fully recovered. And patients are starting to understand that their length of stay is shorter, and that means they may be recovering at another level of care. It just means they're stable and they don't need to be at that hospital level of care. These talking points that you have with your patient are really important, and how you sort of preface the whole discharge planning process. And again, lots of influences on your patient's transitions, including our case management department. So the interdisciplinary team can have a big impact on our transitional planning. So bedside rounds, as I've been saying. Now, you may say, well, we have our rounds in a conference room, or we have our rounds in the nursing station. That's a good start. But the Institute for Healthcare Improvement, IHI, as well as the Joint Commission, are now telling us that bedside walking rounds are best practice. You may have an additional discharge planning rounds, but I like to see that embedded within your bedside rounds. You may need long-stay conferences for your complex patients or particular patient problems. You can have meetings with finance as well as others on those under and unfunded patients. You may have issues with the patient and or family that requires an offline conversation. So these are adjuncts to those bedside rounds. These are more in-depth conversations that you're not going to have on bedside rounds. And then the perennial discharge lounge that comes in and out of favor has to do with where you might need to put patients during periods of very high occupancy, as we talked about before. When we look at case management, we know that some patients are going to need more intensive care coordination and others less intensive care coordination. And so you can use a number of different processes to help you determine which of those patients are more complex. And I just listed for you here some of the things that you can use as indicators. It could be length of stay, it could be frequent flyers, it could be specific chronic conditions or specific physicians or high charges on a patient. These are just ways in which to identify those patients that you may need to have a team to look at in a more comprehensive way. You also want to develop goals, length of stay goals, first for your predictable populations, and those are typically your surgical patients. Your surgical procedures usually are much more predictable in terms of outcomes. Who are the critical team members? What are the process time frames for you to achieve your goal? Your goal could be a particular length of stay or a particular amount of resource consumption during each one of these, quote, phases of care. So for each process time frame, like we just looked at, you want to look at the expectations for the core functions of case management. So for us, during the hospital phase, we're going to want to look at utilization management, care coordination, the discharge planning process, and resource management. And we have to kind of toggle and jump around and manage all of these pieces. Of course, it depends on how your model is set up, but when you have an integrated case management model, this is how it all kind of comes together. And tracking of your data is also important, whether it's your length of stay or avoidable delays, where patients are actually going, because again, that's going to affect that efficiency measure. Those readmissions and denials all sort of become part and parcel to some kind of a report card that you might be tracking. So case managing your Medicare patients, because the efficiency measure right now is based on the Medicare population, I'm not at all, and I want to be really clear, I'm not suggesting you manage your Medicare patients differently, but you want to be sure you're managing them as well as your commercial patients. I often see that sometimes, because we're sending reviews into commercial insurance companies, that we spend more time focusing on those patients than the Medicare patients, but we have to give due diligence to our traditional Medicare patients as well. And working with our physicians, collaborating with next levels of care. Do you do those follow-up phone calls after discharge to make sure that patient's okay and isn't going to come back to the emergency department? Managing all your functions and collaborating between the RN case manager and the social work case manager, because we also know that social determinants of health are going to be a factor that might affect our efficiency measure, because they may slow down the length of stay. So the social worker is going to look at those high-risk psychosocially complex or maybe behavioral health or chemical dependency patients or other indicators that you might have in mind. High-risk issues should be coordinated with physicians and the ED and hospitalists and others. Also, collaboration with the next level of care provider as part of your role as social worker. You're looking at resource consumption as well, and discharge planning, and of course collaborating with the RN. Another role that some organizations have put in place is a home care coordinator, following the throughput of home care referrals and looking at the outcomes of home care agencies. This could be built into another job, also knowing the star ratings of those post-acute facilities, which we are mandated to do now. And then non-clinical support staff. This is becoming a new burgeoning, if you will, role as well. Coordinating the role of the case manager, social worker, and home care coordinator, among others. Aligning the hospital with those post-acute providers. This person can be an analyst. One of the things I find is the poor directors of case management are trying to manage the department but also manage data and report writing, and that is difficult. So having somebody to help you to do that, but also collaborating with other departments and other physician groups as well. So when you look at your cost and you're looking at ways in which to impact your efficiency measure, you have to understand where a lot of the waste is in the treatment of patients. And the Institute for Healthcare Improvement gave us some of that data a few years ago, and it's all the things we know: unnecessary admissions as well as readmissions, healthcare-associated infections, adverse drug events, unwanted end-of-life services, unrelated tests, delays, not following the physician's orders, no critical thinking, contaminated blood cultures. So these are the ones they came up with. And while it's not on the slide, January 27th, Modern Healthcare came out with additional potential savings as a percent of estimated waste. So they said 56% of your waste is related to failure of care delivery, 49% failure of care coordination. So there you go, 49%. Overtreatment or low value care, 28%. So what they're saying here is with better care coordination, you could improve with better or less low value care. And these are important metrics to bear in mind. So you also want to look at your long-stay patients as a subset. These patients should extend beyond an expected length of stay that you have determined. So maybe it's 7 days or 5 days or whatever you like to do. And one of the positions I also recommend, titles not important, discharge planning specialist, usually a social worker, but somebody who's looking at these long-stay patients that are really time-consuming and can take up a lot of the time of the social worker if they're the ones doing the discharge planning, and so they get diverted by these complex patients. When they get diverted, the other patients may stay longer than they need to. So this position can be very helpful in moving the less complex patients along and having somebody expert in managing these complex patients. So it's something to think about if you've got many of these patients, or if you're a high Medicaid or Medicare population hospital. Another tool is a discharge timeout. When you think about it, we all do due diligence when the patient comes into the hospital. There's so many standard things that have to take place on the point of admission. Do we think about it the same way at the point of discharge is really the question. And so we call it a timeout because, of course, we have history with timeouts in healthcare. But this is a timeout that's based on a list of items that should be completed before we safely discharge our patients. So I've listed some of those here. And I've done it as a checklist, so as each care provider, each member of the team completes one of these, they check it off. And if they're not all checked off when the patient's ready to go, then the patient doesn't go. So it's a good way to be sure that everything has been done that can be done for that discharge to stick, really, and not have that patient come back. And then those follow-up phone calls. These are some of the questions that I like to see asked. Did home care arrive? Now, the ones that we know are so common. Did you fill your prescriptions? There's lots of literature showing now that at least half of all your discharges aren't even filling their prescriptions. So programs like Meds to Beds are important to make sure at least the patient gets the prescription filled, and then hopefully they're taking it. So when you make these calls, are they going to see their physician? When are they going to see them? Can they get there? Because these are all the things that, if not completed properly, are going to bring that patient back to the emergency room. And then also the same notion for transitional time outs for patients who are moving within the acute care setting and making sure, that everything is moving along. And this is something you can talk about on your rounds. So that good communication, both verbal as well as perhaps electronic. So you may want to think about, if you look at that third bullet, transitional minimum data sets. So you have a baseline of information that should be shared. And this can also reduce your or avoid some unnecessary readmission. So the reference is there to look at transitional minimum data sets, and do take a look if this is an issue for you when people are in a standard way communicating with each other. And you also might want to think about a transitions case manager. This is a great role for somebody who finds these patients, these high-risk patients, while they're in the hospital, and then follows them telephonically up to 30 days after discharge. And if that patient is being followed by a case manager in the community, well, then there's an interface with that person or home care or whatever it might be. And you can identify those patients based on criteria that you might develop. So it might be in readmissions or specific diagnoses or high cost, whatever works for you. It's a great position. And then your documentation, as we talked about earlier, is really important. So what goes in the medical record, what goes in your case management software, separate from the medical record. And if you, in case management, are putting all of your data in an electronic medical record, you have to be really thoughtful about what is going in there that becomes part of that patient's medical record. Communications with payers really don't need to be in the patient's clinical medical record. Avoidable delays certainly don't. Agreements or disagreements with denials, and even the anticipated discharge date, anything like that really shouldn't and doesn't belong in the patient's medical record. So the difference in the best case management department, a good case management department, and the worst isn't the number of problems they have. The difference is how well they deal with their problems. So how do you assess your own hospital's, or excuse me, case management department's effectiveness as it relates to care coordination? I've listed some things here for your consideration, this slide and the next slide, and you can ask yourself as a team, and do these things as a team. Is it working well? We haven't tried it yet. We need to try it. Tried it, and it didn't work. And I might add, tried it, didn't work, but we want to try again, because that often happens too. So these are all the things that can help you with your care coordination, which will help you with your efficiency measure, and here's the second half of that. So take a look at this. It's pretty much everything we've talked about today, and maybe a little bit more. So you, case managers, as the care coordinator, are the captain of the efficiency team. So you must have certain effective characteristics, clinical competence and experience, timely identification of transitional plans, and working to coordinate and facilitate your patient's transitions. Use evidence practice wherever you can. Monitor the patient's stay, not just at the end of the stay, but every day. So it's part of what we do as we're trying to make that day and that stay both be as effective as possible. Make sure the documentation is there, as we talked about. So these are really all the things we've talked about. Manage your avoidable delays and work on collaborating with all the team members. You directors, you leaders, you want to make sure you have the right staffing ratios, that you have the best strategies you can, that you have the right people in the right jobs with the right skill sets. And I'm not one to believe that social workers and nurses should all be doing the same thing, because we have different skill sets and different kinds of education. Make sure your staff have the tools that they need to be successful. Also, the 5-star rating for skilled nursing facilities, we're going to be moving off this soon. I'm not sure exactly when we get the impact data, but right now this is what we're using. And of course CMS is mandating these quality numbers now, so you have to keep that in mind again. So work with your post-acute providers to optimize your efficiency score. That means, I believe, monthly meetings with them to make sure everything works as expected, and that if you do have an issue with a post-acute provider, maybe you can work it out with them if they're one that you would like to continue to do business with. So we are one of the collaborative members of the solution as it relates to the efficiency member, because we also are one of the business members of the solution. We bring business intelligence to the table, and we bring a continuum of care focus. So for you to change your efficiency measure, you've got to bring that focus, and you've got to be sure you're aligned with all the other departments and disciplines. So you want to have the right model, the right roles with the right functions, those aligned relationships. Also, how do you educate current staff as well as new staff? Do you have the right competencies, and do people get updated frequently? Are your processes hardwired, and what are your physician relationships? All questions you can ask yourselves. So some of the things to leave you today: daily rounds, engaged physicians, processes consistent among key staff and physicians. So doing things the same way, reducing variation. You may want a traditional role or some hybrid model role. We have to look at it. Internal care coordination as well as external care coordination and transitions. With that, I'm going to turn our program back to Sarah to see if we have any